Good morning. Chris Ohl, Wake Forest School of Medicine, Infectious Diseases. It is the Thursday before Halloween, and we'll talk a little bit about COVID this morning. Probably won't be quite as long of a talk as we usually do, as things are slowing down both in the news world and the case world. Cases continue to drop across the country, still the most in the northern tier of states. In the West, New England, some of the states, particularly New Hampshire, Vermont, and Maine, case rates are going up, and again reflecting rates of vaccination in states. The lower your vaccination rate, the more likely you are going to have a wave. Here in North Carolina, our cases continue to decline, albeit slowly. It's a little sticky, a little pokey in its decline. Here in the Triad, we hit 18 per 100,000 for 7 days, where I think this time last week we were about 24. I've been watching it over the last week or two. It goes down about one tick every 2 days, which means that by Thanksgiving time frame we'll be right around 10 cases per 100,000 per day if the current rate of decline continues. And our percent positive should be well over 5%, which means that we can start talking about maybe taking off indoor masks. And there'll be some nuances, and I'll update people on how that goes, because it may not be completely in all settings, but I think in the majority we can. But we got three more weeks, so be patient. Our rates in kids are going down a little bit slower, actually, than the rates in adults. So we'll have to take a look at that and see what we can do about our school systems and as far as masking can go. The one kind of wrinkle in getting back to normal is that we have to get through respiratory virus and flu season yet this winter. And so it's kind of like getting off the big busy highway, and now you're on a kind of a busy side street, and you have to navigate that in order to pull in the garage and get home. I'm thinking that again our respiratory season this year will be a little bit difficult for primary care offices, because we'll have to test upper respiratory infections, colds, to find out whether or not it's flu, whether or not it's COVID, or whether it's just one of the other run-of-the-mill cold viruses. So I think our ambulatory care settings, i.e. the pediatrician's office and such, are going to be busy. The other thing that is a little bit of a concern for us in public health is that our hospitals are still fairly busy. So, for instance, with COVID, we're about a third of the number of cases that we were seeing at our peak in the very first part of September, last part of August. But that's still 50-some cases in the hospital, for instance, in our setting, in our health system, including a couple handfuls of patients in the ICU. So there is still COVID in the hospitals. They're not coming down quite as fast. The other thing is our emergency departments remain quite busy, and it's not all just COVID. There's a lot of people hitting the EDs who have been kind of not getting their healthcare needs taken care of over the last 2 years, and then all of a sudden it comes to a point where they need to. People running out of medicines, people running out of home oxygen and things. So, that happened when we had our primary surge last winter also, but it's happening now following the Delta surge. So please don't neglect your other health, including your mental health, and we'll talk more about that in a minute. And then the other thing is that if your condition's really not an emergency, please don't go to the emergency department. Use your primary care physician in urgent care rather than hitting the EDs. Our EDs are usually, in a normal year, busiest during respiratory virus season, January and February. So we want to try to make sure that our hospitals don't get overwhelmed with non-COVID care as well. The other thing I wanted to mention was mental health. So, one of the things that I think that COVID has brought out is that mental health is just as important as physical health, if not maybe more so. And it's really been, we've had a 25% increase in hospitalizations for depression. Visits for anxiety are also way up. It's, it reflects, I think, a bit of a fragmentation of our normal social order, and it just makes it harder. I think that people need to be able to think about that. It's okay to think about your mental health. It's okay to ask for help from your family, from your friends, from your clergy, from healthcare professionals. Please do so if you're feeling that things aren't right for you, or that it's getting too hard to just keep going. 2 weeks ago here, we had the Run for Joy here in Winston-Salem. 750 people turned out to have a 5K run down Salem Creek. Great, wonderful morning, and it was all in celebration of Caitlin Beardsley and her memory, and that all the proceeds from that went for mental health in healthcare providers, which is a very important thing, because that's one area where the stress has been more than others. So along those lines, the CDC just yesterday recognized the mind-body connection, and that mental health is now a condition just like diabetes or heart disease or lung disease or any of the other underlying conditions that put people at higher risk for COVID complications and hospitalization. And people with who have underlying mental health problems and can also get a booster vaccine, and probably should, just like if you had heart disease. Schools and our daycares and universities are perking along and doing well, actually. Case numbers are pretty good. Masking's helped a lot in all of those settings. I think the schools probably will need to hang in there for a couple, 3 more weeks at least, wearing their masks until we can get our community rates down, particularly in kids, and also give kids a chance to get vaccinated, and more about that in a minute. Just to go through boosters again, we talked some about it last week, but if you were last week at this time, the ACIP hadn't yet met, and so we talked about the hypotheticals about what it would be like, and it turns out that is what it's like. So, first thing you have to do is decide, do you need a booster? If you're an adult, do you need a booster? Here's the people who needs a booster. People over the age of 65. People who are over 50 and under 65 who have underlying medical conditions, including now mental health issues. And then under 50, if you have serious medical health problems, which means like you see a doctor every week or month or two for your condition. Then the next group would be people who have a lot of forward-facing and thus have increased chances of COVID transmission. So workplaces where people work close together, community settings such as universities, congregate settings, perhaps teachers and schools, and perhaps healthcare providers in those settings. And those are people who should come by and get a booster. And then lastly, anyone who got J&J as their initial vaccine needs a booster. So I'll say it again. Anyone who got J&J as their initial vaccine needs a booster. That booster for the J&J people preferentially should be a messenger RNA vaccine, such as Pfizer's vaccine or Moderna's vaccine. If for some reason you don't want that, the messenger RNA vaccine, would prefer a second J&J, that's okay. But preferentially, the immune response is better if the second dose is a messenger RNA vaccine. So just about everyone who was giving initial COVID shots are giving boosters now. Employee healths, including ours with our health system, we'll start be giving them daily starting next week, because we'll have gotten through flu season's vaccines and the work that had to be done with that. So that's the latest in booster news. Just as a reminder that for Pfizer's vaccine, the booster is a full dose, just like the original vaccine. It's no different. For Moderna's, the vaccine booster is a half a dose. And so you only get half the volume in your arm, and probably a little less muscle soreness with that. For kids, we're perking along. The FDA has met, the panel. The FDA panel said, yes, kids between the age of 5 and 12, clearly the benefit of getting vaccinated outweighs the risk. The clinical trials that were done to evaluate pediatric vaccine, COVID vaccine from Pfizer, look great. Efficacy well over 90% for protection from symptomatic disease, and no serious adverse effects found. There was some muscle site soreness, just like the adults got, and there was a little bit of fever the day after, which you can take Motrin or Tylenol for. But other than that, it was smooth sailing. So the ACIP will meet on this next week from the CDC, and following that, the vaccine rollout will occur. Lots of questions about how will vaccine rollout occur, because I think people remember last year when we rolled it all for adults. We've actually been planning for this, both at the federal level, at the state level, at the local level. And rollout will occur in 3 waves. Certain vaccine provider sites will be in wave 1, some will be in wave 2, and some will be in wave 3. The waves will be separated by about 2 weeks. Wave 1 is mostly reserved for people who have high volume vaccinations, as reflected by what we did last year, and then also pediatric sites, so how many people vaccinate kids, and so we actually gathered that data and looked at that. So Wake Forest Baptist Health, Novant, Forsyth County Health Department, at least in our county, are all on that list, and there will also be some pediatric providers, I think. Can you get an appointment for that yet? Largely no. I can't speak for all the private pediatricians' offices, but the health department, the scheduling should come out very soon, in the next few days, through their the internet site, so you do it online. And Wake Forest Baptist Health will also be accepting appointments roughly about the time the ACIP met, and that we know exactly when our vaccine is coming. Vaccine will be distributed from the federal government to the state, and then from the state to the local vaccine providers who are in wave 1 first. Hang in there, be patient. There likely will be more demand than supply during the first few weeks, but you will get your opportunity to get your children fully vaccinated by the Christmas holidays, and so that's good news. And given that our COVID rates here locally are going down, we have a little bit of breathing room to get that done. Do I recommend vaccination for the 5 to 12-year-olds? Absolutely. I have absolutely no concerns, and I will be getting my own child vaccinated who is in that age group as soon as it's available to her. And this is why should you have a child between 5 and 12 vaccinated? There's several reasons. One is to keep your child from getting sick, which is a good thing, and most people would not want their kids to be sick. That's not what parents do. The second thing would be to prevent rare complications of COVID that can occur in children, including multi-system inflammatory disorder. And then to get through quarantine and such, if you are exposed and you've been vaccinated as a child or as an adult, you don't have to quarantine, which means you can still go to school and you can still go to work. And that's a good thing. So virtual school becomes a lot less of a potential risk for your child. And then lastly, if we can get that age group vaccinated to a high extent, then the chances of having to mask again in the future, should we have another wave, are going to be much lower for our schools. And our rates in the community will also go down, because one of the vectors that we've seen for transmission of COVID during the Delta wave has been children because of their social interactions. So it'll help us get out of the pandemic faster. So this really is, I think, a big deal. The dosing for kids for Pfizer's vaccine is a third of the adult dose. That has been shown to provide the same immunogenicity as the adult dose. So kids get a little bit less, which makes sense. They're smaller. So. And I think it'll be the same way with Moderna's when that's released. The needle size for the vaccine, I think it's the same, although I can't 100% attest to that, but it should be the same, because the adult size was very small. For those of you who are checking needle size when you got your shot, it was a little bee stinger needle rather than the bigger ones we use. So, it really is not shouldn't be an overly painful event. Less so than a tetanus shot or the yearly flu shot. Speaking of flu shots, looking at some local data, our flu shot uptake rate this year is much lower than it should be. Why? I'm not exactly sure. I can guess. Maybe people are fatigued by vaccines and the whole idea of doing it. Second thing could be that people just simply haven't been able to do it because it's harder to schedule these things when you're busy and when other things are going on. Or maybe they think that the COVID shot covers the flu too, which has been a misconception that I've seen. But none of those should really be a factor and get in the way of the flu shot. As I mentioned earlier, I think flu is going to be an issue this year. And flu also can land you in the hospital, particularly if you have underlying medical problems or at extremes of age. It's not quite as bad as COVID. Mortality and morbidity is not quite as bad, but it's still formidable. So we need to get our flu shot, and I think it's important to not forget that this year. And there's still time. Don't worry, you haven't missed the boat. A little bit of about treatment for COVID. First thing I want to remind people that monoclonal antibodies are still available. In fact, the shortages seem to be easing off some. If you have COVID, if you get diagnosed with COVID and have a positive test, particularly if you're immunocompromised or if you have underlying medical problems, or older than 50 or so, you're going to want to get treatment. And the monoclonal antibodies are one way to do it now. Wake Forest system has monoclonals available in High Point here in Winston, and then also at a FEMA site up in Wilkes County in Wilkesboro, which is now going to stay open until November. So if you're up towards that area in one of the mountain counties where I'm sure the trees are gorgeous right now, then that's where you can get a monoclonal. Molnupiravir, which is an oral drug, should be coming out sometime around the Christmas time frame, give or take a month. And that'll be an oral treatment that we'll be able to get by prescription. And that actually looks pretty promising. I haven't seen all the early data on it yet because it hasn't been totally released. But what's been released so far from the company looks great. 1/2 reduction in hospitalization and death for people treated early. Some news this morning, Fluvoxamine is an antidepressant that's been out on the market for a while. And because of its anti-inflammatory aspects, has been studied as having potential COVID, anti-COVID activities. And a study that was just done in Brazil was released by press release. It's not yet been peer-reviewed or really scrutinized. That came from Brazil, where they treated people early who got COVID, and then measured how many went to the emergency department or got hospitalized. And it reduced that number from 16% to 11%. The company called this a major breakthrough. I guess that depends on how you define a major breakthrough. 16 to 11%. It's okay, but it's not wonderful. The other thing is that hospitalizations and ED visits for COVID are much more common in Brazil than they are in the U.S. So whether or not that reduction will be seen here in the U.S., we'll have to wait and see. There is a trial going on here in the U.S. with that drug, including at Atrium Health, Wake Forest Baptist, and that trial hasn't closed yet, so we don't know the data. I would probably wait until we have more data before jumping on getting an antidepressant. And by that time, Molnupiravir will be out, so it may be a moot point. Halloween coming up. Let's have a safe Halloween. All of the usual things apply. Get some, reflective straps and reflective trick-or-treat bags, and make sure you can be seen. Go in groups with other kids and friends, and wear a mask. It'll also help keep you warm, and because it will be chilly, I think, this Halloween weekend. It's much better to be trick-and-treating outside than to be doing it indoors. I still would avoid the big indoor parties. For you adults who enjoy a good Halloween party, get the patio heaters out, take it outside, fire pit time, and keep your gathering small, because it makes it easier to gather around the fire pit if there's not a lot of people. And bundle up, and we'll have a great Halloween this year. So I'm looking forward to it. So with that, any questions?
We have one just asking if we could give some more detail on mixing booster shots.
Oh yeah, the mix and match for boosters. So the one area where you really kind of have to pay attention a little bit is if you got J&J, because I think you probably should get a messenger RNA vaccine as your booster, and that's pretty socked in. If you got Moderna, should you get Pfizer or Moderna? It probably doesn't matter so much. If you got Pfizer, and should you get Moderna or Pfizer as your booster? It probably doesn't matter so much, because both of them, when we looked at the studies, did really great in boosting, whether you got the same or you got a different one. So probably what it's going to come down to is, what does your vaccine provider have? Moderna's a little bit harder to get right now. There's a lot more Pfizer around. So when you go to get your booster, if you need a booster, then if they say, well, we got Pfizer, then you can say, that's okay for me, and that's fine. If you got Moderna and they said, we got Pfizer, that's okay. You can do that too. So.
And then if they got the J&J vaccine, how long before they can get a booster?
Yeah.
And then also for the mRNA, how long?
Right. So if you got a J&J vaccine, when can you get your booster? 2 months. Anytime after 2 months. Because as I mentioned before, it's really like getting a second shot of the initial series. And so anything after 2 months. For the messenger RNA vaccine, 6 months. 6 months later.
And then the last one is, could you explain the difference between a third dose and a booster shot?
Oh yeah, so a third, well, the third of a dose is basically a formulation made for kids. Kids are smaller, so they don't need as much antigen. So we give a third as much antigen. The volume it's in, though, is the same. It's just a third as much of the immune activity agent. A booster vaccine depends a little bit on which booster. So for Pfizer, it's the same that we used for the initial series. For Moderna, they did a study using a half of that. So, and that's actually half of the volume. So rather than, I think 0.5 cc's, it's 0.25 cc's. So don't worry about it. You don't have to figure it out. Your vaccine provider knows. So.
One more, I just thought of this. For immunocompromised people, do they get a booster or do they get like another vaccine?
Yeah, so for immunocompromised people, we call it a 3-shot series as their initial series. We don't use the word booster because it would be confusing. And there is actually some information now that people who are very seriously immunocompromised, people who have leukemia, lymphoma, if you're seeing a doctor regularly for an immunocompromising condition or medication, you know it. It's not a secret. And those people might actually benefit from a 4th dose. And we also have information now from a study that we participated in here looking at when to immunize bone marrow transplant patients. It's a little bit specific, but if you've had a bone marrow transplant, you know that your immunity went away when you got your transplant because everything you were exposed to earlier no longer exists in your immune system. So we have to revaccinate those people with a full 3-dose series. So. Any other questions?
Yeah, a couple here. So there was that national report about hospitals seeing an increase in very sick people who had put off care. Asking if it's something we're seeing here locally, and
Yeah.
people to not put off needed care.
Yeah, as I mentioned earlier, yes, we're seeing more people presenting with stages of their illness or disease, or a relapse or an exacerbation, or things getting worse. And we are seeing that locally here. I think probably everywhere in the country they're seeing that. It's no different here. And a lot of it's showing up in the emergency department, and that's not good because it makes the ED busier than it needs to be or should be. And we want to be able to take care of real emergencies rather than people who've put off chronic medical care. So if you haven't seen your doctor in a while and you're supposed to, it's time to go now. Get that done so that you don't end up in the emergency department.
I know you touched on this earlier, but anything more that you want to elaborate on, any recommendations or time frame that we might want to begin thinking of easing of mask mandates?
Yeah, I think, I mentioned it a little bit earlier, looking at how our rates are declining, and then about some other things like Halloween, and we always have a bit of a spike after Halloween, and then the rates in kids. I would think it's going to be probably around Thanksgiving time frame, and for us here in this area. New Orleans eased their mask mandate this week, but I looked up their rates to see what they're at, and they're in the area right now where I think we will be right around Thanksgiving. So it kind of makes sense. And why is New Orleans ahead of us in the decline is because they had a lot higher and earlier spike in COVID than we did.
Kind of go on that, you talk about, we may see some easing around Thanksgiving. Is there anything, with the winter coming on, should people still worry about, it seems like every time it looks like it's getting better, you know?
Yeah.
This variant came out. Is there any other variants that's?
Right. So yeah, kind of a double question. What about respiratory virus season? Will we see another COVID wave or surge? And then also, are there any new variants coming about? There's one variant that's kind of popped up in the UK, which some have called like son of Delta, or forget how it was termed. It's Delta with one more mutation. And that's been there now for some time, several months. And it's reached like 8% of the population of COVID people now. And so it's not really like taken off like a hot charging, racehorse like Delta did. So, and it's not a variant of concern from the WHO or from the CDC. So it seems like the variant propagation may have slowed, knock on wood, or and hopefully it stays that way, because mutations can always occur. The respiratory virus season in the winter, COVID, will increase again in January and February, but it will not increase nearly as much as it did last year. It will, but we'll also be seeing other cold and flu viruses. And this brings up the point. So if breakthrough infections for vaccinated people are largely a cold or flu-like illness, it's pretty rare to get stuck in the hospital with it. And it's the same thing with flu. So if you get your vaccines, it's more of an annoyance than a problem. But yeah, it does. That time of year does make our hospital busy, because 20% of pneumonia admitted to a hospital in normal times is due to a respiratory virus, not a bacterium. So I mean, it's something. I mean, we get really busy during that time of year anyway. And you remember some flu seasons in the past where we've had to put a tent up in the ED parking lot. I don't think we've done that here, but some hospitals have. So just flu can make it busy.
We got two more questions in the comments. The first one is, can you get a different shot if you have heart problems? Like, is there a best vaccine to get?
Can you get a different shot if you've had heart problems? So this is probably reflecting the very small number of cases of myocarditis that have popped up in younger adults, from the messenger RNA vaccines. An exacerbation of heart problems that you might already have. So and the CDC and the WHO and me all say that you can get a messenger RNA vaccine if you've got heart problems. In fact, we even say that you can get it if you've had a history of myocarditis in the past, because it doesn't, the incidence doesn't seem to be related to that. And just to recount, the numbers of cases of myocarditis with the messenger RNA vaccines is somewhere around 50 per million, 50 per million. That's pretty darn low number. And actually, your risk of getting myocarditis from getting COVID is much higher, because it can cause that. COVID can. So, and the other thing is we haven't had a death from myocarditis. I mean, everyone recovers pretty quickly, actually. Most people now aren't even being hospitalized. So.
And then the second question is, 12-year-olds need to get a second dose because second shot, since they get a full dose. Many countries are only getting one. What's your opinion?
Yeah, I think here in the United States, we are saying that the kids between 5 and 12 should get 2 doses. Just like adults did for their initial series. The UK is doing one jab, as they say. But here in the United States, we want the full protection that you get from having 2 doses. And that's what the studies were done with. All right, very good. 30 minutes.